Dr. Frances Mair, and if you were here for the kidney session, she kind of alluded to the fact that she is one of the co-authors on the original We Need Minimally Disruptive Medicine paper that was published in the BMJ in 2009. So we are actually celebrating a decade of minimally disruptive medicine thanks to Frances and team. So it's a pleasure to welcome you, Frances, and please share with us some of your work about the challenges of multimorbidity.
Okay. Thank you very much. It's been 5 years since I've been last at the Mayo Clinic, and Victor will be pleased to say I've changed a couple of slides since then. Yeah. But I'm going to be talking more broadly about multimorbidity and polypharmacy. So I'm going to start off with work talking about the polypharmacy multimorbidity, and then move on a bit to talk a bit more about treatment burden, and then going to go on to capacity issues, and then finish up with some concluding thoughts. And I will make sure that I get to time so that I know you've had a long day, but that we then move on to the next session. So just to acknowledge the team, my co-authors on that first paper, Victor and Carl, and also the wider team. And I've missed Ian's name off the list of people, and there are quite other people I've missed off the acknowledgements list. But thanks to people here at the Mayo and also in England and back in the UK. And just to acknowledge some of the funding we've had for this work over the years. So these days, chronic illness is endemic everywhere across the world. Even in low and middle income countries, chronic illnesses, non-communicable diseases are the biggest healthcare challenge facing everyone. And multimorbidity, people having 2 or more long-term conditions, is now the norm rather than the exception. So we see patients who have polypharmacy, all these tablets. You see the person with the low back pain, but they have also maybe have diabetes, and they will also maybe have chronic obstructive airways disease or other conditions as well. Now, our healthcare systems are configured very well for acute care, and this very nice hospital here is the Queen Elizabeth University Hospital in Glasgow. It was finished just a couple of years ago, and it's the biggest hospital in Europe. It's a fabulous place. And if you have your heart attack, or you have your major trauma, and you need to get flown in, or you have your stroke, it is where you want to go. It's a fantastic place. But I would suggest that if you have your chronic illness and multiple chronic illnesses, that it is entirely the wrong place for you to want to go. And that actually the way we have our healthcare services configured internationally just now is not fit for purpose for our patients with multiple long-term conditions. And that we had healthcare systems set up because of the problems that we had last century, acute illness, acute infectious diseases, and that if we were starting from scratch to develop healthcare systems for the problems we face today, they would probably look completely different. And if I just talk back about the idea of treatment burden and think about this very lovely hospital here, just last week I had to go and collect my brother-in-law post-surgery, and he's quite heavily multimorbid. There's no place to collect your patient from the ward here that you can easily. So if you're a relative coming to collect somebody who's got mobility problems and needs a wheelchair, there are about 2 parking spaces. This is a huge, huge hospital, but there's about 2 parking spaces. So it required really 3 of us to go collect him. Somebody parked way up there. My sister went and got a wheelchair and took it up to get him. And then my son collected 2 Zimmer frames, which the ward was giving us to take home for upstairs and downstairs and everything else. And that is what I think is an aspect, for instance, of burden of treatment, is not thinking about the patient's needs. This is a fantastic hospital. It's gorgeous when you go in. I'm sure it will win all sorts of awards. And they do provide fantastic care. But a lot of the time, our healthcare is not configured to make things easy for the people with the healthcare conditions. So you've seen a version of this slide previously today, and this is just going to show, this was a colleague of mine in Glasgow, had this patient where had this paper in the Lancet where he looked at over 1 million people in Scotland, a population survey, and was counting up the number of chronic conditions that you have. And you can see obviously that people are developing their multimorbidity, multiple chronic conditions quite early in life. So it's not the older, very old people who have this, but actually at younger age groups. And if you look at the red line, I think the very interesting point is that refers to the most deprived people in our populations who get their multiple long-term conditions a full decade earlier than their more affluent counterparts. And that matters a lot because having multimorbidity is associated with increased all-cause mortality. So this is us looking at people who've got no long-term conditions, then 1 and 2 and 3, and then 4 or more long-term conditions. And following them up over 7 years, you can see how their mortality rises. And that's all-cause mortality. But equally, specifically, they'll also increase their cancer mortality and their vascular mortality in the same way that you can see as you increase, basically a dose response, as you increase the number of chronic conditions, then it increases your risk of dying. But we've been trying to look at that, to look at people with multiple long-term conditions and think, well, what patterns of multimorbidity and what kinds of people are most at risk of bad outcomes. And one of the things that we see when we're talking about how multimorbidity is occurring at younger age groups now is looking at the effects on outcomes as well for people of different genders, different socioeconomic status. And here you can see that on our data using UK Biobank, which is a population cohort of over 500,000 people in the UK, that it's the younger people, those people in their 40s who have the greatest mortality if you've got multiple long-term conditions. So though the absolute mortality may be highest in older people, the relative risk of mortality is actually higher if you're a younger person with multiple conditions. And also, I think it's important to consider what kinds is all multimorbidity the same? Because we talk about it as if it's a homogeneous population, as if being multimorbid or having 2 or more long-term conditions is the same thing. It's a kind of homogeneous group of people. But in fact, it's not, and there's a lot of work to do to look at what clusters or what patterns of multimorbidity are associated with the worst outcomes. But we've just done some initial work which has been looking to show that cardiovascular, cardiometabolic multimorbidity, having multiple cardiovascular conditions, will increase your risk not just of all-cause mortality, but also of cancer mortality, as well as, unsurprisingly, vascular mortality. And I think there's a lot more work that needs to be done to look at what patterns of multimorbidity, combined physical and mental health comorbidity, are going to be worse for patient outcomes. And I think also just relating to the fact that I showed you that slide which showed that people with, from more deprived backgrounds, more socioeconomically deprived, get their multimorbidity a full decade earlier, but they're also, this is people from the most deprived population, have a higher mortality rate. So if you add your socioeconomic deprivation and your multimorbidity together, then it really has a worse effect on your outcomes. There isn't an interaction, so it's not a multiplicative effect, but there is an additive effect of being from deprived background and being multimorbid on your mortality. So if you've got multimorbidity and you've got multiple long-term conditions, then as unsurprisingly, then you're going to be very likely to have polypharmacy as well. You're going to have to take multiple different tablets, and those multiple different tablets are going to have multiple different side effects, and they may interact. And it's been known since, here's a report from the WHO in 2003, that as you increase the complexity of treatment regimens, that affects people's adherence, their ability to comply and to take the medications as they are prescribed or as they are intended. So we live in an era of evidence-based medicine, and we have to follow the evidence. But I would say that we have a big problem just now because our evidence is all about single diseases. And you've got the guideline for diabetes, and your guideline for COPD, and your guideline for depression, and there the twain shall meet, because they don't really speak to us. And some of the guidelines, so if you look at the heart failure guidelines, they will mention comorbidities. Some other guidelines for conditions like rheumatoid, less so. But even when you look at the heart failure guidelines and you look at comorbidities, in the section in the guideline referring to that, it's a few pages, whereas it might be 100+ pages for the whole guideline. So it's still a relatively small piece of the puzzle here. And so we have a problem with the evidence that we're using to inform the management decisions that we make for people with multiple long-term conditions. And I think there's a big problem with that, and I'll explain a little bit more why I say that in a minute. A year or two ago, The Lancet had a series called the Right Care series. And it was making the point that often people are undertreated, and certainly pharmaceutical companies and healthcare systems are usually very quick to pick up if we fail to treat somebody enough or give them enough of different medications. But equally, we overuse medications. It's always easier to add a tablet, but deprescribing or taking somebody off a tablet, that seems so much harder. And I think we're a lot slower to do that. And I think a key point is, though, most of the care that we provide falls into a gray zone in which the benefits and harms are not clear, and where attention to patient preferences and their goals and beliefs is probably the thing that should guide what we do. And not enough attention, I think, is taken to this issue. And I think this plays very well when people are talking today about shared decision making, and why that is increasingly important when we live in a world where some of the evidence underpinning our decision making is quite shaky, and where there isn't a definite right or wrong, and therefore we really need to take account of people's preferences and what they think is the right thing to do, and there are reasons underpinning those decisions. So I just want to give an illustration from this is a patient with stroke that took part in some of our studies, and I think it illustrates very well why people with polypharmacy and multiple long-term conditions can be at risk of bad outcomes or problems, and we have to be careful. So this lady was saying, there was a chemist I had to go down and see at the health center one day, and he wanted to discuss my medication. He said, you need to be on aspirin. I said, no, I think from what they said that caused me the problem. And he said, oh no, you definitely need to be on aspirin. And I said to him, you better go and check up on that. So he went, and he came back and he said, you're right, you shouldn't be on aspirin because she'd had a GI bleed with it, and that would have made it worse. And I think this just is a kind of example about the dangers that there are when we have fragmented care and people have multiple conditions, and the potential to make mistakes. People could be following the guideline carefully, but if we're not paying attention to the holistic pattern of all the problems somebody has and everything in their past medical history, then we might be doing them a real harm. So last year we had a paper where we were looking at how much co-prescribing went on of drugs that have similar adverse drug reactions. And what we were looking at was people who had chronic obstructive airways disease, chronic obstructive pulmonary disease, versus people who did not have that condition in the UK Biobank cohort of 500,000 people. And we looked at medications which had people at risk for these outcomes here: falls, CNS depression, urinary retention, constipation, bleeding, or renal injury. And we were just looking at how commonly people were co-prescribed these medications, or these combinations of medications. So this is just cross-sectional work. And you can see here how common it was for people to be on, who had chronic obstructive airways disease, to be on multiple medications with the same risk profile. So a lot of co-prescribing of medications that would be risky. Now, I think it's important to be clear that sometimes that's the right thing to do. So if you're a patient with heart failure, you are going to be on multiple medications that have falls as a risk factor. And that we know that there are benefits for doing that, because actually if you're on those ACE inhibitors and beta blockers, you know, and some of your diuretics, then those can be beneficial in terms of mortality, in terms of reducing your hospitalization and improving your quality of life. So I'm not saying that co-prescribing of drugs with similar adverse reaction profiles is always a problem, is always wrong, but I'm just saying you have to be aware of it as a risk. And one of the things that I think is important to look at, that this is really just showing, this was initially looking at people who didn't have COPD, and then we have people who have COPD within the sample overall, and then we're looking at them alongside each individual comorbidity. So we're looking at people's COPD with pain, COPD with mental health conditions, COPD with cardiovascular disease. And you can see immediately the size of the circles indicates how common co-prescribing of drugs were, with the risks at the bottom: falls, bleeding, renal injury. And you can see, therefore, if you have cardiovascular disease and chronic obstructive pulmonary disease, you're very much at risk of being on multiple drugs that are going to cause you falls. Whereas if you've got a mental health condition, you're likely to be on multiple drugs that put you at risk of GI bleeding. So our point here was really, is if you looked at the single condition of chronic obstructive pulmonary disease, well, that's really not why they're on some of the risky prescribing. It has to do with their other conditions that they have alongside it. So the fact that you're taking you've got cardiovascular disease alongside your chronic obstructive airways disease makes you more at risk of having multiple drugs taking that cause renal injury or falls. And if you've got mental health conditions, then you're at risk of combinations of drugs that cause bleeding or urinary retention or these kinds of issues. So our key message from a lot of our work is really the importance of clinical guidelines to take account of the problem of comorbidity or other conditions, and focus on the person in front of you who has multiple conditions rather than just on the single disease. So polypharmacy is common, and co-prescription of multiple drugs with similar adverse drug reactions is common. We said, as researchers often do, is that future research should examine the impact of these patterns of prescribing. And we haven't published this yet, but I'm just going to show you some of our preliminary data that we're working, hopefully have our paper in before the end of the year, which is looking at just this problem of co-prescribing. Because as a family medicine doc, when I do a prescription, I work in a practice that's 100% computerized. So when I prescribe a drug, if I prescribe a non-steroidal ibuprofen or something like that, and then I add in an antidepressant like sertraline, when I want to add in the second drug, my computer system will come up and say, you know, warning, increased risk of bleeding. So it'll give me a warning. But it doesn't really tell me when does it become a never event. So we sometimes have to co-prescribe things with the same adverse drug reaction profile. But is it prescribing 2, 3, 4 of them? Does that become a never event? So we've been looking at that, and just looking at when you co-prescribe for renal injuries, you know, 1 drug, 2 drugs, or 3 drugs, how likely you are to get renal injury over 5 years. And unsurprisingly, you can see your risk goes up. We've been looking at bleeding, the same kind of thing is happening. But more importantly, we're also looking at the individual medications, because between those classes of drugs, there are multiple drugs that increase your risk of falls, for instance, or there are multiple drugs that increase your risk of renal injury. But what clinicians don't know, and what's really important if we're going to have very meaningful conversations about shared decision making, is which actual drugs in those categories are going to carry the greatest risk. And I think it's kind of phenomenal, really. And I think a lot of patients might be surprised. I'd be interested to see what our patient representatives in the room think about the fact is we actually don't know the answers to this. And our computerized systems don't give us a measure of that risk. So it makes it difficult for us to have meaningful shared decision making when we have such big evidence gaps. Okay, so I'm going to move on to this now to talk about treatment burden and minimally disruptive medicine, the work that started with Victor and Carl 10 years ago, where we were really talking about these people who've got multiple conditions, who will be given more and more things to do, more and more advice about changing lifestyle, taking these tablets, going and getting these blood tests. and the fact that patients can increasingly become overwhelmed by that. We might be following all the guidelines, but patients are overwhelmed, they can't adhere to what we're saying, and then you get bad outcomes, and you have wasted resources. And I think a good example of this is I had a gentleman come to see me in my practice a few weeks ago. He was on about 20 different medications. He had hypothyroidism, he had depression, he had had a previous stroke, he had coronary artery disease, he had chronic pain. And he came into me, I think about a rash or something, and I said to him, oh, you're taking a lot of medication. And he goes, oh, no, I'm not. I go, yes, you are, look at this list. He said, oh, I stopped taking them ages ago. I said, how are you feeling? And he said, terrible. And I said, well, I'm not surprised, and kind of went through some of the things. And so I think we think we're doing all of these things, and I have these problem lists, and you know, we probably would have scored quite well if people had looked at our quality indicators, because we were taking his bloods every so often and doing all the right things. But were we doing him any good? I think the answer is no. And therefore, I think we need to think more carefully about what we're doing. And I took this off of Twitter a few weeks ago, because this was a sign a lady, quite rightly, had put up, and she was complaining about her child had multiple conditions, had some congenital health problems, and had disabilities. And she was saying, you know, I went to see my GP, and this sign was up, and I have all these problems, and this is just a nonsense. And I have seen these signs up in GP practices in the United Kingdom. I know why they have them, because we have 10-minute appointment slots. 10 minutes is not sufficient to deal with multiple complex problems. I mean, that gentleman who came in who was not taking his 20 medications, it was quite fortunate because it was my last slot of the day. So I then spent time with him. But I have to say, if you told me that first thing in the morning, I'd have thought that pile of people waiting outside, I would have been very stressed. And so I think this is to say that we have healthcare systems configured, so not just on the hospital sides with these big centers of excellence, but also in our primary care, which we have them set up in ways that are not fit for purpose, that are going to increase people's treatment burden. And actually, it isn't efficient, because if somebody can't get their problems dealt with, if I can't deal with them when they come to see me, well, then they just turn up at the emergency room, and then they bounce in and out. But actually, if we were able to spend time and help them address their problems in a more meaningful way, in a way that works for them, I think we'd be much more successful, and we would save on our resources. And so I wrote a piece a couple of years ago with Cara May saying, well, we need to think about the burden of treatment as being a barometer of quality of care, an indicator of quality care, and Victor took up the mantle with his group, and he and others here have developed, there's 2 measures of treatment burden have been developed here, and another one in the UK, because if you can measure something, doctors are happier about it, but also if you can measure something, then you can intervene and see if you can make a difference for it. We've talked a lot about treatment burden today. Treatment burden and illness burden, I see them as 2 overlapping things and concepts. And just to be clear, when I talk about illness burden, I'm talking about the symptoms. So I'm a patient with chronic obstructive pulmonary disease, and my breathlessness and my fatigue are my illness burden. My treatment burden are all the medications I have to take for them, the fact that I have to come and attend the appointments, the changes in my lifestyle that I have to adopt. These are obviously overlapping concepts, but I think that they both matter. And in healthcare, I think we've been so focused on illness burden that we've forgotten about this other bit, and we ignore it, and I think we do it at our peril. So what is treatment burden? Well, I gave you a very quick 3-minute description earlier, and I was talking really about the renal patient, but I think, again, just to reiterate, it's about the work that people have to do to learn about their illnesses. And as we advance in healthcare, we increase the technologies and all the things that we can do, but that means that patients have more to learn. So if you're a patient with heart failure now, not only do you have to learn about the medications that you need to take and the lifestyle changes you need to enact, but you also have to learn about the devices that we can use that can help you. Your cardiac, your synchronization devices, your defibrillators, but also the implications for those as your disease might progress. and what are the implications of deactivating defibrillators and things of that nature. You have to think about engaging with others to get your prescriptions. That can be hard work too. I have asthma and I'm not very well organized at getting my inhalers. And so I had put in a request where you have to put in 2 days ahead in my practice to get your inhalers. I put them in 2 days before I was going on a trip. So I needed to take them with me because I just was near running out. And so I then went to the pharmacy to get them because it's arranged, so we have a prescription and the pharmacy picks it up from the GP practice, so you just go and collect it just to aid efficiency. So when I went to the pharmacy and my flight was at 4 o'clock and this was at 11:30, they said, well, we don't have the prescription, it hasn't come. They said, you need to go back to your practice. And I went zooming to my practice, but when I got there, actually, it was just after 12 and the practice closes between 12 and 2. For that information. So then I had to wait till 2 to go to the practice, and they said, oh no, we've sent it to the pharmacy. So I then said, look, I said, I'm actually out of time, and they really told me they don't have it. I said, can you phone them? And so I kind of stood over the receptionist and was kind of, okay then, you know. And she phoned, and they said they don't have it. And she said, well, we have sent it to you. And then she said, okay, she got one of the doctors to phone the prescription across, and then I ran to the pharmacist again. By this time, get my inhalers and go straight from my flight, thinking, oh, there's never going to be organized. But I mean, I think we underestimate the work people have to do to just engage to get things for their treatments. And then this work of it, you know, taking the medications, putting up with the fact that, you know, you're on a diuretic for your heart failure, you have to run to the restroom. So, you know, if you're going somewhere, you either miss it out or you kind of have to plan where the restrooms are on your route. All of these things we don't think about hardly at all. And then the work of deciding whether they're going to stop all their treatments, like the gentleman that I saw and told you about, or whether they're going to keep on taking them. And what we said 10 years ago is that we need minimally disruptive medicine and less SINC, which stood for structurally induced non-compliance. And what we were really saying was that it isn't patients who are just non-compliant, as we doctors, kind of health professionals can say they just, you know, need to do better. But it's actually the healthcare system that contributes to that, and that we need to provide more person-centered care, and then and better information, and then that would lead to better treatment adherence and better treatment outcomes. And we've done a lot of qualitative work in the UK as well as colleagues here in the Mayo have with patients. And this was, and you can see it's a Scottish patient saying I, but this was a patient who had advanced heart failure weeks before he died. And so we were talking about barriers and facilitators to care and the treatment burden that they experience. And I think it's really quite sad to see somebody a few days before they die to say, I feel it's for the institution, it's not for the patient. Everything is geared for smooth running. That means it's from the hospital point of view and not the patient's view. Right or wrong, what do you think? And I thought he was right. And we had done work with patients with advanced heart failure and work with their caregivers. And we delivered a report to the local health authority in our area. And one of the things that patients said was most difficult was emergency admissions. And the ones who had the best experiences were the ones who managed to arrange a backdoor admission to cardiology, who, you know, their heart failure got worse, they got more breathless, they phoned their specialist heart failure nurse, and she arranged for them for a direct ward admission. And the ones who had the worst experiences were the ones who just had to turn up at the ER and wait for hours, and they said it took a long time, and they were moved about. And when I gave this report to the health board, they said, well, that's very well, but we're not doing that, because they said they had streamlined their emergency services. They didn't want these backdoor admissions because they said, you know, we're trying to see, you know, numbers being admitted, and we're trying to get our workflow better organized, and they all have to go through the front door. And I said, that may be, but it suits the hospital. It doesn't suit the person necessarily. And this is a folly. So I think the treatment burden arises because we give people lots of treatments to take, but also because of care deficiencies, because of the way we deliver and configure our services. And I think somebody this morning talked about reimagining. And I think we need to reimagine our healthcare services. And I'm trying to do more work with low and middle income countries and talk to them about this and say, you know, maybe you shouldn't develop healthcare services that emulate those in the high income countries. Maybe you have an opportunity to rethink what you're doing and to do it differently. So I think we need to reduce burden of treatment, and that simple can be beautiful. That we need to encourage coordination in clinical practice, that we need to improve communication between primary care and secondary care, between social care and health care. We need to acknowledge comorbidity in our evidence, and we need to take account of capacity issues. I'm going to turn now to talk a bit about capacity. And I know that some people will be able to stay for capacity coaching on Wednesday, and I'm getting to stay at least for half of that, so I'm looking forward to that. But we know that there's an interplay between burden and capacity. And somebody else mentioned this morning about how it is that they can have patient X comes to see them and they're on 5 medications or 20 problems and they're just fine. And they tick the box and then they're fine. And they have person B come and they have that same constellation of healthcare problems and medications and they're a disaster. And why is that? Because people will vary in their capacity, and capacity is not a fixed thing. So somebody might be managing fine right now, but next year they might not be. And I'm not going to spend too much time thinking about that, talking about these, because we've talked a little bit about the cumulative complexity model and Carl's rethinking the patient burden of treatment theory, but I just want you to be aware there's a literature that talks about that. And, you know, cumulative complexity model really just takes you through and show you how as social and clinical factors accumulate, people can increase their burden of illness, their burden of treatment, and their capacity to manage and self-manage can be affected. And there's a nice figure in Nathan Shipley's paper which talks about patient workload and demands and then about capacity, and how these things affect healthcare outcomes. But I want to give you an example of a real person, John, who has, and just to give you an idea of how illnesses and problems accumulate and how they can affect capacity. So John started off with polymyalgia. It was really bad, and he was on high-dose steroids for a couple of years. As a result of that, he developed diabetes. And he also needed to be started on medication because his bone density decreased for osteoporosis. He then also developed atrial fibrillation and had to get on medication because of that. And then he also had hypertension in the background, and then he went into acute heart failure when he had a rapid run of his atrial fibrillation. When he got admitted with his acute heart failure, he was found to have underlying coronary artery disease. And he has also developed peripheral vascular disease. So John has had a bypass, heart bypass. He's had a carotid endarterectomy, and he's had vascular surgery on his legs. He has to arrange to take his medications each month. He has to take 10 different medications at different times of the day. He has to endure the side effects of those. Lightheadedness has been a problem with some of them. He has to attend multiple clinics. He attends the vascular surgeon, he attends cardiology, he attends the practice nurse for his diabetes, he also sees the GP. He has to make a lot of changes to his diet and his physical activity, but that's not the only work that he has. His mother has dementia and she's in a care home now. His father has beginnings of cognitive impairment. He also has atrial fibrillation, and he has frequent blackouts when he gets admitted to hospital. He has an older brother with severe chronic obstructive pulmonary disease, learning disabilities, and poor mobility, who lives about an hour away in Edinburgh. Does he have any fun in life? Well, yes, he actually has a young daughter of 8 years old. And how does he manage? He probably manages because he has a very supportive and very able wife who keeps a spreadsheet of all his conditions, and when he goes back and forth, helps him to manage. So you can imagine what might happen if this support disappeared, and how John could go from somebody who's managing to somebody who's not. So we've done some work to look at capacity and really have come up with these 6 areas. Katie Gallagher in my group has led this work to think about these different factors. I'm just going to run through them quickly. And one of the things we've been trying hard to do is to get data just to show how these things affect outcomes. Because one of the concerns I have, and I was speaking to Victor about this, is that over a decade, you know, we've been talking about this and things have been slow to change. There have been changes, but it's slow. And I think part of that is people think that maybe treatment burden and capacity issues are soft issues and not as important, for instance, as your hemoglobin A1C for your hard outcomes. And I think what we're trying to show is actually these really are important for your hard outcomes. So if you think about personal attributes and skills, then people need to have all these personal attributes to manage well. And if you don't, then you're disadvantaged and your capacity to self-manage is going to be adversely affected. And there can be lots of things. So language can be an issue for you. If you don't speak the local language, it makes it very difficult for you to understand and make sense of your treatments, of the information that you get given. If your health literacy is poor, which is much more common than many of us think, then that is going to affect how you understand things. There was a study done in the UK a few years ago looking at health literacy, and they found that almost half of people in the United Kingdom had trouble understanding the Tylenol dosing instructions for their children. Okay? Now that's pretty surprising, and I don't think it's just there. When I worked for a while here in Kansas City a long time ago, people in the US I found used to know a lot of the terminology and would use a lot of medical terms, but when I sometimes asked them what they thought they would mean, they often really did not grasp those concepts as well as you would think. And then there are the things as your illnesses, your multiple chronic conditions affect your ability to self-manage. They affect, you know, if you have visual or hearing impairments, that makes it more difficult. If you have cognitive impairments, which can affect you, then that makes it more difficult to remember to take medications. Then you look at the multiple conditions that can affect your well-being. And frailty. Frailty coexists with multimorbidity. So if you're morbid, you are more likely to be frail. But they are a bit like illness burden and treatment burden. They are overlapping concepts. And these things can affect outcomes. So I want to just say that people will vary. People with different illnesses and different combinations of illnesses will be quite different, even at the same age. So we need to tailor our care to suit the individual. So we've done some work where we were looking at frailty. We used an adapted frailty phenotype to look to a population of 500,000, and we were from age 37, so not older people. And we looked at weight loss, weakness, slow gait speed, low physical activity, and exhaustion, and categorized people as being frail or pre-frail. And you can see that 37.5% of people from age 37 were pre-frail and 3% were frail. As you increase the number of chronic conditions, the amount of frailty increased. But importantly, really importantly, was that your mortality over 7 years was more than doubled from the age of 45 years of age for men and women if you were frail. And that's after adjusting for your lifestyle, whether you smoke or physically inactive, and after adjusting for the number of long-term conditions you have. So it's not just, so it's another concept. What I would say is a capacity issue can affect your healthcare outcomes. Then we talk about the support network. And we mentioned John, who had his wife who was able to help him. And there's this wider support network that can be a great benefit to patients or might not be. And there's also data from UK Biobank that show that people who are socially isolated will have a greater mortality, again, after adjusting for these kinds of risk factors. So I think these things matter and affect healthcare outcomes. If you have financial struggles, if you are unable to pay for aids and supports, if you can't pay for your transportation, for your hospital visits, it's more difficult. Where I work, that Queen Elizabeth University Hospital is the nearest hospital. But by public transport, it takes my patients 2 buses to get there. If you've got mobility problems and visual problems, that's going to affect you. If you've got money to pay for a taxi, it will make your life easier. Where you're located and the nature of your environment will affect your ability as well. And I just show you this picture. This is in Scotland. This is a nice park near where I live. And this is in the east end of Scotland, the Easter House. There is a 10-year difference in mortality between these two parts of the same city. If I give my patient with diabetes and heart disease lifestyle advice and tell them to go for a walk for an hour each day, who's easier to do? Somebody's going to walk around that park, or somebody's going to walk there where they're maybe worried they're going to get mugged, or it's not very nice or appealing. So I think we don't think about these things when we give advice. How easy is it for people to adhere? And then we think only about people and their chronic illness and not about the wider life experience that they have. And you know, the life workload, that person who's multimorbid is the person pushing the person in the wheelchair. So we don't think about that they might have a job that takes up a lot of time, that they might have other caring children that they have responsible, and actually that they might want to have some fun or do things that they enjoy. Gosh. Victor led a group that did a review looking at interventions to reduce 30-day hospital admissions, readmissions after a surgical or medical admission. And they looked at these interventions. And those interventions that did something were more likely to improve individual capacity, were statistically more likely to reduce readmission. So I just want to reiterate that I think capacity matters. In my university where I work, precision medicine is very popular. And for a general practitioner, I'll agree with them that multimorbidity, we need a precision medicine approach. But my definition of precision medicine is probably a bit broader than some of my specialist colleagues. And I would say precision medicine for me, for our patients with multiple long-term conditions, is medicine that's tailored to people's needs and that takes account on genetic, environmental, lifestyle, and capacity factors, as well as their personal goals. Rear Admiral Grace Hopper was the first female admiral in the US Navy. And she made this statement, and I think it applies to our healthcare systems today, that the most dangerous phrase in the language is we've always done it this way. And that seems to be the reason we do lots of things in healthcare, and I think it has to change. And I think we need to remember, when we talk about people with multiple morbidity, these are real people with multiple different problems, and we need to individualize care for them. And for implications for practice, I guess my take-home message to all of you is, if you just ask 2 questions of your patients, can you really do what I'm asking you to do? And do you think what I'm asking you to do is the right thing for you to do? Thank you.
Thank you, Frances. We have a few minutes for questions.
Thank you very much, Frances. That was fantastic. I remember being at a conference about 3 years ago, and we were presenting some data on multimorbidity in Western Australia. And what surprised us was that the outcomes for the most deprived and the least deprived were identical. We could not understand why that had happened. This was in Peel in Western Australia. And it happened to be Frank Jones's practice. Frank Jones was then president of the RACGP. We said to Frank, can you talk to your partners, why is this? Because this is not what we were expecting. And he said, it's because, funnily enough, it's exactly the experience that you were describing, which is that the rich farmers who lived in this particular area would phone up and say, I need my repeat scripts for my metformin or whatever else happened to me with diabetes. Never set foot in the practice. The practice would be very nice to the nice old gentlemen in those areas, issue the prescriptions, and they got substandard care.
Or comments?
Comments, yeah.
Exhausted after a long day.
I know. It's hard to close day one because, man, people are feeling the energy
Could you go back to the slide just before that?
I
Like
was
the
just
questions you
gonna
asked.
ask, I was just going to ask you to do that too. I wonder if I might add one.
Yes.
We have a third, well, it might be the second one, but what valued direction does the client want to go in? So it's not just can you do it, or do you think that what I'm asking to do is the right thing for you, unless implicit in that is that that's going to pick up their values. Does that pick up their values?
It's meant to, but maybe we need to articulate it a bit more clearly, because I think one of the things we've been doing over the years is producing new papers that expand on and develop things as we learn. So I think yes.
Yeah, and these questions came from 2014, and 2014 was the year we embarked on beginning to develop ICANN. So that tells you we're evolving quickly.
Well, and on that, I wonder if removing the I statement, because that can also that implies judgment. That this is what I think you should do, right? To the point of maybe it's knowing what you now know about what some of the best practice might be. Does this seem like something you might be able to do?
Yeah.
So it actually kind of puts more on a level footing, like it removes that power imbalance, and so puts both the provider and clinician and patient on a level footing.
So I absolutely agree with you. This was written in the BMJ, so it was aimed really at health professionals, and actually, in a sense, I was kind of wanting them to think before they speak. Actually, to be considering this, and actually, it's really, in a sense, meant to be that prompt for that kind of shared decision making, where rather than just saying, "This is what you should do," to kind of take a step back, thinking, "I think they should be doing this." Maybe say, "Okay, this is kind of an option here. This is what I would normally kind of recommend. What do you kind of think, or what would be your view on it?"
Yeah. So just more prompting the healthcare work.
Well, yeah. So it's meant more as an internal prompt, I think.
Okay, so with that, we're going to close the first day of official business. We have 2 activities this evening. Next, if you have any energy at all left, we will be walking to the Castle community. Victor and Maggie will be sharing some work from the Patient Revolution there in a more relaxed setting. And then taking place afterward is the dinner. If you're joining for that, you can go straight from Castle. We'll walk there. Or if you do want to come to dinner and don't want to go to Castle, you can certainly go take a nap. So feel free to do whatever's best for you and your body. Please be joyful this evening, and we'll see you back in this room in the morning, wherever we see you tonight. Thank you.
I'll be back. We'll be back here if anybody who wants to walk over to Castle.
Sounds good.
What is Castle?
What is